So Ray Sterner is a developmental behavioral pediatrician, and he's the one who's speaking right now about something that we're really passionate about, and we agree with both of who've spoken so far that doctors are often not taken very seriously along these lines, and yet there are many times when children's learning problems are not being taken into account properly.
So maybe we can come back to talking about how to work with school systems, because we have some passion about that too. But today the focus is really on learning disabilities, and the segue is through our view of kids as they appear for ADHD care and evaluation, and with the recognition that really the adult outcomes of ADHD are more related to academic performance than to ADHD per se. And so what are we talking about here? And there is a great overlap. You know, you talked about the school system language and the medical language, and there are some language issues right at the beginning of this. And we continue to talk about learning disorders because DSM-5 has continued that terminology. When we go over to the school side, they may be talking about learning disabilities associated with ADHD. But those the concepts are really the same. And so what we recognize is that of the kids we're taking care of with ADHD, many of them have a learning disability. And the surveys vary, and they vary really by whether it's from family sibling cluster studies or school system-wide studies. But a quarter to really kids with ADHD will be found to have some disability. And the flip side of kids with learning disabilities, about a quarter to half have ADHD. So there's a great overlap, and we're going to focus on the learning area. And when we're talking about learning, and the DSM-5 talks about learning disorders, and they also talk about a category of communication disorders. And I just wanted to overview what we're talking about here in these two big, broad areas. And when we look at what is a language impairment, and we have these categories: dyslexia, dyscalcula, the math problems, written expression, and as though they were all different things. And what we'll come back to is that we really might be talking about developmental variants or variations in behavioral outcome with shared risk factors, because there's a lot of overlap in these issues. But I'm going to focus on reading and math, and first reading. And so we all know, and we've heard this phrase, we need to learn how to read so one can read to learn. So early grades, learning to read; the rest of life, reading to learn. But if you don't get by the learning to read part, the rest of your life gets bogged down, essentially. And so within reading disorders, and that term is no longer in the DSM-5, the term that you'll see is dyslexia. They didn't include the other acknowledged reading disorder, which is on the comprehension side. But I'm going to focus actually my remarks on dyslexia. And that term's been around for a long time, and has had a lot of confusion associated with it. It's a really very simple concept. The concept is it's a decoding impairment. It's an impairment of mapping the phonemes, that is the speech sounds, to graphemes. And graphemes are like printed letters, also called orthography in fancy language. But it's the sound to the letter, that linkage. And the main takeaway about dyslexia is that those things are linked, and it's the decoding sounds to the printed word that we are really talking about. And so reading words and non-words aloud to see if a child can generalize from, you can go over and over and drill them, and do they generalize some kind of sounding out rule? And if they don't, the process gets bogged down for them, and the issues become one of accuracy and speed. So if you're having trouble and you're slower at figuring out the sound letter associations, and then you do it at a slower speed and your comprehension is fine, but when you're asked or forced to speed up the process, your comprehension is compromised. So it's an issue of decoding, but the end point is speed. Putting those things together, we call it fluency. So in the DSM-5 definition and any definition of dyslexia, what we're talking about, of course, it's related to the age of the child and IQ, and independent of IQ. The idea is that it's not just about low intelligence, it's about a specific learning disorder, and it does imply a certain amount of exposure to education, or lack in the new parlance of the education system, lack of response to RTI, response to therapy intervention. So that's the phonemic processing, decoding part called dyslexia. Then, not to be confused with reading comprehension disorder. So those kids can read fluently, but they're somehow not understanding what they read. But they read it just as fast as anyone else. And this is something related to oral language comprehension. And so if you talk to the kids, you do some language tests, you'll see that they're weak in vocabulary, the grammar is faulty, and there may be a problem with their working memory also. So there are two reading issues, one dyslexia and the other comprehension, two separate things. So dyslexia, again, we're talking about kids, and pediatricians get to see this emerge really in those kindergartners and even preschoolers now. There's a big emphasis in many of the preschools on recognizing letters and words. They have trouble with that, even though they're smart kids. And then understanding the connection between letters and sounds, that's called phonemic awareness. They may, in their speech, you may see even some misordering of syllables of words, and when they have trouble with rhyming kinds of games and words. So if they're having trouble associating sounds with words, on the flip side of this, they're going to have trouble spelling. But to the extent that spelling in the English language has a lot of phonemic decoding needed. And so, as I said before, the problem is the speed's compromised, and if the phonemic process is so laborious and diverts their attention, comprehension is going to be an outcome that's a problem, but it's not the key, it's not the cause of the problem. So we think about dyslexia now as a neurobiological phenomenon. We know that it runs in families. Overall, in the prevalence about 5%. Within a family, the family history is 44%. And studies vary on how it's male to female. There's slightly more males to females. There's some controversy about that. It shows up in other cultures and other languages. It so happens that English language is a particular stress test for dyslexics because of the combinations of the possible sound associations and blends that are not phonemic, and there's a little more phonemic rules associated with English language, but it shows up in all the other languages too. And that's from a notion that the family associations, there have been genetic studies, and there have been at least 9 different gene loci, 8 different chromosomes identified through these family studies. And we know by fMRI, functional MRI, that they tend to process differently regarding the connection between the language areas and the visual spatial areas, and it is more processed in the left hemisphere, and there are white matter differences as well. Now, to try to be up to date and sort of understand this from a medical point of view, we want to look at the genes and see what the gene products are. So we could give some kind of biological intervention. But it turns out that these candidate genes are more general kind of ones that affect neuronal migration, right, outgrowth, but there is no mapping between the gene and a process that's impaired in dyslexia at the moment. So, and here's a picture where you can see the sort of a MRI functional, this is with the reading single words. You can see that there is a problem, disruption of posterior reading system connecting this language sorting area with some of the visual areas in dyslexic and not imperative, and that's pretty clear. So we talk about dyslexia as a categorical problem. It actually, another way to think about these things is NIH is trying to get us to think about dimensions in all of the disorders. It's all, and you could think of dyslexia spectrum disorder. You could say ADHD spectrum disorder too, by the way, and any other thing. But the severity of dyslexia relates to if there is some language weakness, ADHD, or how smart the child is, and we need to think that dyslexia sometimes is isolated dyslexia, that's it. But there's a lot of comorbidity. So you got dyslexia with ADHD, you got dyslexia with some language problem. The language problem could be more grammar, it could be more vocabulary. It could be that this child who has articulation disorder and already has another reason to have trouble discriminating and producing sound and blending them into their native language. And then math disabilities in 25%. So we're thinking about the individual child. There's a dyslexia phenomenon, but they may be burdened and with other associated phenomena. So if we were going to do refer a child for dyslexia evaluation, what would you expect? I think it's worth going over this. So there's one test, it's called phonological awareness, and that's exactly what it's trying to test for, phonological awareness. Now, there are others one of the favorites of the school psychologists is the Woodcock-Johnson, and there is a sound blending subtest. And then there is the comprehensive test of phonological processes, and the NEPSI is one that's popular. But a test that measure, try to isolate and measure how a child deals with sounds and segments sounds into words. For example, you might ask a child, if you take what's left of the word, if you take the first sound out of cat, they have to be aware of the association. And then you might say ba and Anna and ask them to fill in the middle sound. and these middle sounds are more difficult than the initial sound. So that's the kind of phonological awareness testing that might happen. And then there's some tests that focus on the decoding part. And an example is the test of word reading efficiency. And there are others. Again, the Wechsler intelligence is one that the school psychologist would use. And there is a subtest that has a pseudo word decoding and a Woodcock-Johnson. So what we're looking at here is reading aloud single real words and fake words, pseudo words. It says HIFF or MIGH, Majoran, something like a Majoran. Some having been trying to apply the rules for matching units of sound to written symbols to see how they sound out things and how quickly they can decode these words. And this is important because some kids will be reading at grade level, but they're memorizing visually words instead of applying the rules of phonics, and it becomes laborious for them. And then there are some tests that get at how rapid, this rapid automated naming test, and how quickly a child can name common letters, numbers, objects, colors on the page. And so this is important because we want to know, it's all, the process we're talking about is one that has to do with time. How quickly can they retrieve the phonological information and automatically code it and respond? And then putting it, you want to know how do they put it all together. So there's fake words, and then there's decoding single words. But then in the real world, they have to put it together. Now there's the gray oral reading test board called, and there again Woodcock-Johnson's got a subtest, and there's some others as well. But the child reads a passage out loud and answers some questions, what they just read. Then there are some cards, letters and numbers, pictures, and they name them as quickly as possible. The idea here is a real-world assessment of how quickly they can read words in context. And the kid may be reading, but they do it so slowly. So how do we help these kids? Well, the problem is really a discrete one that has to do with sounds and letters and associating them and doing it as quickly as possible. So the best interventions are ones that look like overlearning and drilling, those kinds of dad, bad, did, words that are look alike but have different, some small differences make differences in sound, and you drill faster and faster. There's some other tasks that have to do with rhyming. Which of these words, cot, rod, bird, which ones rhyme? So it's really drilling with these things. Orton Gillingham is praised. Two individuals were associated with this kind of work. They started it in the 20s and 30s, and you know what? The basic idea of what they were doing really still holds and makes a huge difference. The earlier, the better. And the Sally Shaywitz and her husband Ben Shaywitz, neurologist and educator, studied this kind of intervention and looked at functional magnetic resonance imaging. And guess what? If you really hammer at this, you can change their fMRI, their neurophysiology. And so there's nothing simple about it, and it's a kind of intensity that is hard for mom to do with her kid. It really requires, probably it's best for someone who's not related, who can motivate the kid and have them go through these flashcards. That's the other ways to do this, but that's the essence of the effective intervention. Excuse me. So there are all kinds of success stories of dyslexic people who self-confess. Whoopi Goldberg, John Lennon, Steven Spielberg, Walt Disney, Henry Winkler, Alexander Graham Bell, Jay Leno are some of the individuals who have come forward and said, they described their childhood and how they've overcome it. And you can see in some ways they used alternative pathways. They didn't get a PhD, none of these. Sometimes Einstein included. It's always it's not clear about Einstein because he was such an unusual person. But I won't invoke it. So how about for a comprehension disorder? What does the intervention look like? Well, basically, the interventions for comprehension disorder involve working on the oral language skills that underlie the condition. So the vocabulary, we work on vocabulary and grammar, and sometimes speech language pathologists get involved. You have to be careful because they're prone to working on articulation, their favorite thing, and not the language, underlying language problems of comprehension disorder. So now I want to switch from reading to arithmetic, Dyscalcula. So, it's really interesting. About the same percentage of kids who have reading disorders, dyslexia, have math learning disorder, about 5-6%. And again, only a subgroup have isolated. The only thing they have is a math problem. 2/3 of the time it's going to be comorbid. And these same kids with dyslexia are doubly cursed sometimes with a math learning disorder and ADHD. And by the way, if you've ever watched some of your ADHD kids as they're starting to read, and it's so hard to know, there's this frustration, intolerance that all kids hit as they're starting to sounding out. And how many times have I been thinking, is this the ADHD problem with impersistence, or is it for dyslexia? And so throwing in ADHD is it changes the picture for math and for learning. Sorting that out, we'll talk more about that. Anxiety. Anxiety is associated with dyscalcula, and then later it could be math anxiety, and that does interfere once they fear taking on new math problems. And visual spatial disorders, they used to talk about nonverbal learning disorders, kids who have problems. They may speak well, and but they may have trouble with visual spatial perception. And then kids, of course, who have no experience and they're culturally deprived. So I thought it would be useful in thinking about math to think about some math-related developmental milestones. And there's this word that's kind of cool. It's subitizing. Subitizing. I don't know if you've heard that word, but it means just understanding things at a glance. And it's been shown that smaller babies you can test, primates and birds and bees seem to be born with the ability to glance at things. And they tested that and see whether they differ by one or more. That's something we get early on. And then there's something called approximate number sense that comes on a little later. That's a nonverbal estimate of how many stuff you see, and it's confounded by how far away it is and how groups of stuff. So that's something that is acquired very early on, infants and toddlers and preschoolers. Preschoolers need some years and rote learning to associate the verbal names and visual symbols of numbers, and they gradually. And if you just get 2 things, and they can do 3 things, and it's a slow process. But by the time they get to kindergarten, we expect them to have some one-to-one correspondence enough to count out 5 to 10 randomly spaced objects, and often fingers are used. So, and then there's early school ages. They start to learn something called cardinality. And that's the number of elements in a set, and ordinality, and the invariance of their sequence. That is, that the numbers, there's a number line. And it differs from, this is not just an early approximation, but one is greater than the next one, and they're all lined up in order. And that's what first grade's about, right? Adding 1, subtracting 1, and having to know that what you get is the next one in this invariable order of number symbols that are associated with all kinds of different things. And then, and for some reason, and this has always been interesting to me, if you recall Gerstmann's syndrome. Gerstmann's syndrome, this was a very old, long time ago, there's a neurologist, and he found that some acquired, like, stroke in the area, parietal lobe area, individual, an adult would lose both the ability of math and finger agnosia, being able to tell where their fingers were in space. And so there seems to be some linkage between fingers, this finger counting and actual counting. So then what happens, the kids overlearn, memorize answers, we're hoping, and they code these things verbally, multiplication tables, addition, subtraction, facts. And then what we know as kids get to middle school, and we note the differences in how rapid they can understand math, having to do with being able to estimate the magnitude and make quick number comparisons so they can estimate they're going in the right direction, they're monitoring the results of their calculation, relates to some success in higher math. Now, I want to show you something about the neurobiology of mathematics, and I'm going to show you the brain, the number pathways. And what you see is that when we're talking about mathematics, there's a lot of different parts of the brain. You have to have the visual, to see the numbers, verbal, there's something called the phonological loop, and then visual, there's a visual spatial sketch pad where you can visualize that number just for a moment. And this one isn't so much left brain like the reading. This involves both hemispheres. And then there's this place in the interparietal sulcus, they call it IPS, where there are neurons, particular neurons that are tuned to numbers, like a number line. And then given all these verbal and visual kinds of areas, then you need to have some long-term and working memory to make it all work. You've got to keep it in your mind. And then you have to focus your attention to do it. So there's the executive functioning related to that, this motivation, and then you're not doing well, and you're anxious also. You might have math anxiety, and that makes things worse, and it's hard to work with those kids. So you can see what we're dealing with is has great complexity, and that suggests that there's no universal neurologic cause or gene that explains all these different work types. And what's interesting is that with practice, as people become more proficient in math, you actually see the functional MRI. They are making it more efficient. They don't use all these different components. They may not need to go to the verbal system. It's almost as though, they don't have to. You see kids having to use their fingers, so it becomes more efficient and less parts of the brain are used, except for if you're weak in math or you have dyscalculi, you're going to have a slower process, and you're going to have to go through all these components, and you'll be thinking about your fingers and words that are associated. So now that you know all about math, disabilities, and reading disabilities, when would you ask for evaluation in a pediatric practice? So we think that it's useful to have some kind of grade level standard achievement screen. Now, when I showed you all those tests are tests for breaking it down and saying, okay, do we really have dyslexia? Now, if you're watching a kid from kindergarten, you'll know that as a pediatrician. But if they're just having reading problems and they come in their fourth grade, you may have to break it down. But the main issue for us, I believe, is are they at grade level? Can they do it? Are they fluent in reading? So having some standard reading paragraphs, the Einstein, the RAP, Gray Oral we use. There's an interesting kind of a screen. One is the NWEX. It's a computer-based one, and it presents items, more items if you're weak until you get to a certain level. So it's a more efficient screening test. But basically, paragraphs and then problems. Just 3 or 4 math problems to see whether you're doing what you should be at grade level. And then the other issue is the kid having academic difficulties despite good ADHD control? So in the past, we would ask for an evaluation at school, IEP, right? So now many of the schools aren't going to respond to that, but they're doing what they're supposed to, and they're doing something called RTI, response to standard intervention first. So it looks like they're delayed, but they may be. You have to find out, are they working at that? I would suggest that we as doctors could be proactive also. Now that there's so many online educational suggestions, plus if a child's having trouble getting, especially as they get towards 5th grade, getting someone other than the parent to get in there, maybe the high school student, and do some tutoring and overlearning is the main thing. So in Chattis, we won't get to do that. We won't get into this too much, but we have been looking and will be interested in sharing with people around the country using Chattis or not resources, educational resources. And there's one we came up with called Muzology. And let me just want to point it out. Was related to pre-algebra. So kid gets into middle school, and one of the best predictors of as well as if a child will be accepted in college and go on to college, or even if they're going to graduate from high school, would be how they deal with pre-algebra and algebra. It is a critical juncture, and some kids are really having trouble, and ADHD kids are also. We came across this group in Nashville, and we've been working with them and talking to them, and they say their basic premise is, kids are having trouble learning, but so many kids, they know the words to all kinds of pop songs. Why is that? And what they say is that music lights up the brain, activates memory, attention, motivation, emotional brain regions. Now, this is a legitimate group of PhD developmental psychologists working together with some really good songwriters and producers, and they have evidence that they've improved test scores, self-confidence outcomes. It's hard to show these things through WebEx, and now I'm actually not using my computer where I have it. I would be glad if you're interested, because let me tell you how we're accessing things like this. In Chattis, we have a patient-specific template, and one of them is focused more on ADHD. And in one section of it, you're making a plan. And if the child's having trouble in a particular area of learning or other kinds of challenges, we have some recommendations, and recommendations wired in for the goals that the parents say, for example. And so kids are having trouble beginning in pre-algebra. When you click, they will get into this library of incredible videos with rap singing and so forth, and we can show you that. So that's an example of it. So I'm going to stop now and ask for questions and discussion and cases.
So why don't you make some specific suggestions about what a person in a primary care setting can do? So one of the things that we all know about the physical exam is when you've done 100 of them and you do them in the same way over and over again, you become more aware of more subtle differences. And I think the same thing is true for doing some academic screening. And that's why I like using the Einstein, for example, and the gray oral reading paragraphs, because at this point in my career, I've had hundreds of children read the same paragraphs and answer questions about them so that I have some kind of basis of comparison. The other advantage of using a tool like that in a primary care setting, even within, it only takes you 5 or 10 minutes to do it, less than that, is that the school then is more likely to believe you, because I think Paul brought up an interesting and important point, and that is if the school thinks we have nothing to offer, then they don't hear any of the things we have to offer. And sure, they're better at doing the testing for reading and math than doctors are likely to be because they do more thorough tests, but they're not even going to that point because they're not listening to us at all. So do you want to comment on practical ways of doing this?
Well, that's what I had mentioned earlier. I agree with you, and you could you just watch these kids, and some of them have trouble just keeping their place. The attentional issues, you will notice when they have trouble standing out, how long and how much struggle it is for them to read. And when you do math problems, you'll see that sometimes they get to conceptual areas and they have trouble. So basically, are they on task in a comfortable way? We can, on grade level, we can determine that quickly, and I agree that would be an important part of seeing any kind of ADHD for sure.
I used Mel Levine's system for years, the answer system with pyramid peaks, strands, and those are excellent tools designed for pediatricians to do a learning assessment in the office. I find them far more useful to discuss with the parents than with the school because they have no experience with that. So that's been very helpful through the years. I've learned a lot from it. The second thing I did, and I have done, and I mentioned it earlier in the discussion, was to befriend several of the psychologists. Most of these other school systems have dozens of psychologists. But if you can get some champions in there, they can be very, very helpful in pushing for actual psychoeducational evaluations. And the Medicaid system will cover for private psychoeducational evaluations. And so,
Really?
Unfortunately, in most areas, psychoeducational evaluations are left for the kids who are working 2 years below the expected level of performance, and there's a 1-year delay in getting it, and I can get a psychoeducational in 2 weeks that is superb and has a ton of information. And that has been one of the schools actually do appreciate that. These are people who really care, except they have a limited budget, and they budget to test 2 to 3% of their population, and with 20-25% of kids underachieving, that's not particularly useful. So that's very important, and then checking your state Medicaid system can be very helpful in getting a fast private psychoed, and then if you can work your way into an IEPC, presenting that information can be helpful.
Nice.
The law, the IDEA law requires that they review outside consultations like evaluations. They do not. The law does not say they have to act on them, but they have to seriously review them. But as you say, most schools are welcome information.
I used the Dr. Levine's test too a lot, kind of abbreviated versions of them. They helped me a lot to figure out the kids, especially the kids' attention, memory, and language skills in a quick way. I also used the WASI, Wechsler Abbreviated Scale of Intelligence. It's because it's quick. You know, it's not an exact IQ. I get all kinds of crud from people saying, well, this isn't an accurate IQ. Well, it's close enough, and I don't want to wait 6 months for information from the school, and it's hard, even though the other doctor said it's easy to get the psych ed evaluations from private sources. It can be hard. So I like mine because I want to know now, and I want to tell the parents now what the kids' strengths and weaknesses are. You learn a heck of a lot using the WASI, the CTOP, and the Gray Oral Reading Test. You can learn a heck of a lot in an hour. So that's kind of the way I do it.
You know, I trained with Mel Levine also, and I find his stuff useful. We do have to remember that it's not very replicable between testers. And one of the things that I disagree with him about, he's not around anymore, as you probably know, but is that there's not a formal reading test among those packets. So I'm glad, Dr. Jordan, that you also use the Gray Oral Reading, because having standard reading paragraphs is really important. It goes beyond, as Ray pointed out, it goes beyond single word reading into being able to look at some comprehension or contextual reading.
Right. It's exactly right, because you got to look at everything. You got to look at standardized tests, but you also need some kind of more subjective tests. Not every kid can be given a standard score that tells exactly what he's at. You got to use a combination, and you got to look at everything. It's too bad we have to kind of make up these things on our own, and I wish some outside authority could have something for us. But until then, we kind of got to do it this way.
I wonder if any of you are recommending evidence-based or not evidence-based online learning games and learning interventions. Anybody want to speak to that? Any favorites that you've run across?
Different websites that I do recommend, like Khan Academy,
yes.
is one of the most common ones.
We like that.
I do feel that for my adolescent patients, it's interactive in the computer enough that makes them engaged, and so I do use I would say that's the one. There is another one, and I am forgetting the name, but the one that I use the most is Khan Academy as a recommendation for.
Good. So that's KAHN. For those of you who haven't heard of it, it's actually a free kind of college courses even, and can be very helpful, particularly for teens who are not getting good instruction in some of these subjects in their high school. They don't understand them, or it gives them an extra source of information about the same subject that helps them deepen their understanding. They're really terrific.
Anyone else? How about for the younger kids? Any learning games or phonetic association games you like?
Has anyone had any experience with Fast Forward, University of San Francisco?
Yes. Go ahead. That one has some good evidence to it.
Yeah.
Anybody?
You have to find someone who's certified in Fast Forward, but it's very quick. I mean, it's intensive, and it's a 6 to 8 week course. It can be done at home with tapes, but it should be supervised, I think, by a speech and language pathologist. I think it's beyond, well, maybe some developmental pediatricians are using it, but for general pediatrics, I don't think it's helpful to know about.
Right.
Very good.
Well, as I said, this is a group that may be interested. We are in the process of developing and piloting an ADHD patient-specific template where the pre-visit, a variety of pre-visit questionnaires populate the help you with documentation and recommendations, and bring recommendations to this care portal that each child has, the memory book.